Faculty of Public Health, Universitas Indonesia Science Festival. And for that we will have the last plenary session in 11 o'clock. And we're still waiting for our speakers. Our moderators is actually already here with us. And some information before we start our plenary session about the MEMTech. This is the last day, but still MEMTech is very important because later on you have to show it to take your certificate. And certificate can be taken today for those who cannot come, for the participants who cannot come to this event today. They only will get the e-certificate, not the hard copy one. So if you have your colleagues, friends who cannot attend today's event, you can give the information that they won't get the real hard copy one certificate, but the e-certificate. And also as PPD, for those who need to proceed this PPD, don't forget before 11 o'clock is your last chance. So we're kindly reminding for those who haven't processed their SPPD. We can proceed before 11 o'clock, before this plenary session. Welcome to our today's plenary speakers. So right now you might have already your morning snacks with you or the afternoon snacks with you. Really be careful to put your snacks or maybe laptop on the table in front of your chair because it is very easily fall down. So again, be careful with the table in front of your chair. It is easily fall down. And also for the lunch can be taken after the closing ceremony of the Science Festival 2017. Soon in 11 o'clock, we'll see you again and we'll start our last plenary session. Thank you very much.
Ya begitulah. Lagi ada teman-teman. Website. Oh.
Lupa ya, jangan saya lupa sudah yang mana.
3, 2, 1 lagi Prof. 3, 2, 1.
Oke. Ya, ya.
Once again, welcome to the participants who just arrived in this room. Soon we will have our last plenary session. Once again, I'd like to warn you that the table in front of your chair is very easily to fall down, so very be careful when putting your valuable stuff like laptop, handphones, food. And also today's plenary can be live streamed. So the audience of the plenary is not only the participants in this room, but also those who have the link of our YouTube channel. So it's live stream. You can tell your colleagues who cannot attend this plenary today to live stream from YouTube. Thank you.
Jangan banyak-banyak itu aja. Tapi sekarang saya ya bisa.
For participants who just arrived in this room, please fill the empty seats in the front row first and in the center of this auditorium. So you can choose the empty seats in the front row first. Maybe those who already take the seat in the very back of this room, you can move to the front. And also be careful with your name tag, because you still need it to get your certificate later after the closing ceremony. And using the name tag will cause you to be charged 50,000 rupiah. So be careful. And also other valuable stuffs like handphones, laptops, please do not leave it alone without any supervision. So please take care of your belonging. We'll start our plenary session soon. See you. Assalamualaikum warahmatullahi wabarakatuh. A very good afternoon. Welcome, moderators or invited speakers today. We are now on the last day of our 3 days of Faculty of Public Health Universitas Indonesia Science Festival 2017. After that, we will have our last plenary session, our third plenary session, with the topic of universal health coverage. Already with us, the moderator of the session, Professor Anhari Ahadi, and I will read his CV before Prof. Anhari lead this plenary session. Professor Dr. Anhari Ahadi, SCD, is currently the Professor of Health Administration and Policy Department. He graduated his medical doctor from Faculty of Medicine, Universitas Indonesia, his master in Faculty of Public Health, Universitas Indonesia, and Doctor of Science in Johns Hopkins University, USA. He is currently the head of Center of Family Welfare, Faculty of Public Health, Universitas Indonesia. His field of expertise is health policy, health service management, child and maternal health. So to Prof. Anhari, time is yours. Thank you.
Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. I understand that we still have a lot of abundance of energy today, and we will have our plenary sessions, as it is said, the last plenary sessions, of course not the least, equally important to the others. And the title of the plenary sessions today is Universal Health Coverage, a very important notion that we have today. It is, of course, just to refresh ourselves, our understandings that universal health coverage is a political will. It is a commitment of the global community to provide access of health services to everybody in equal manners with the quality in reasonable levels, and of course will include 4 dimensions of health services: promotive, preventive, curative, and rehabilitative. It is very important developments. I guess that some of you still remember, then this is actually also initiated by WHO. WHO and UNICEF, as we remind ourselves, in 1978 convenes a meeting in Alma-Ata and have a declaration Health for All for the year 2000. And again, also WHO initiates in 2000 and then adopted in 2003 Framework Convention on Tobacco Controls, and then became a convention. And now this is also a product of World Health Assembly of WHO. In 2011, he adopts that universal health coverage should be the political will and should be pursued by the global community. Again, I would like to refresh ourselves that universal health coverage meaning that everybody should have access to health services in equitable manners, in quality, reasonable levels, in 4 dimensions: prevention, promotive, curative, and rehabilitations. And interestingly, that after adopted by World Health Assembly of WHO, and then WHO can convince United Nations, and then the universal health coverage become a United Nations declarations. I will just read it. To achieve universal health coverage includes its senses: coverage with needed health services and coverage with financial risk protections. It is fundamental to strengthen the health delivery platform at primary healthcare level, ensuring that close to clients services are well functioning with adequate medicine, appropriate medical diagnosis and treatment, and staffed by adequate number of motivated and responsive health workers. And then in 2012, United Nations have resolutions on universal health coverage, emphasizing that health is essential for sustainable development. The resolutions in December of 2012 again emphasizing that reaffirm WHO leading roles in supporting countries to respond to the challenges of implementing universal health coverage. This concept has been increasingly recognized in international fora since WHO published the World Health Report 2010, entitled Health System Financing: The Path to Universal Coverage. Again, the global movement steps another things. In 2013, World Bank and WHO also convenes a meeting, and then at Geneva, at ministerial levels meetings on universal health coverage. And it is said that universal coverage implies, it is said there, again emphasize the case of universal coverage. Universal coverage implies that all people, without discrimination, have access to nationally determined sets of needed promotive, preventive, curative, and rehabilitative basic health services, and essential, safe, affordable, effective, and quality medicine. UHC is crucial to increase healthy life expectancy, to reduce poverty, to promote equity, and to achieve sustainable development all together. This is again UN, but again, very interestingly, there is another step taken by economists, not by public health experts, not by medical experts, but by economists. In 2015, economists gathered, led by Lawrence Summers of Harvard University, calls on global policymakers to prioritize a pro-poor pathway to universal health coverage as an essential pillar of sustainable development. Because investing in health makes economic sense. That's what the economists say. So again, the declarations is launched in September 2015, and there are signatories from 44 countries. Again, it is also published in Lancet and New York Times. So, ladies and gentlemen, today we have opportunity to discuss the universal health coverage, how it is implemented in Indonesia, what challenges and actually opportunities to achieve that. We have with us already two distinct, very important speakers. The first is Dr. Annette Robertson. I hope that I'm right to pronounce the name, Dr. Annette. And the second is Professor Hasbullah Tabrani. I would like just to make brief introductions of our speakers today. Dr. Annette attended Fiji School of Medicine, and then San Diego State University School of Public Health, and also then she went to Harvard University for her doctorate degree, a doctorate sergeant in public health. And then after that, he assumes a lot of responsibility of country director of UNFPA in Afghanistan, and then a lot here, in Pacific Sub-Regional Office, and also then finally about 2 years ago, she assumes responsibility as UNFPA country director in Indonesia. I hope that you enjoyed that, children. And I guess that I would like to ask you to stand up. Please make applause to Dr. Annette. No, later. And then again, I would like also to introduce, I guess that most of you have already known him, our second speaker, Professor Dr. Hasbullah Tabrani. Professor Hasbullah Tabrani, I don't need to read this paper because I know that. He was graduated from School of Medicine in Universitas Indonesia. Then he went to Berkeley School of Public Health in California for his MPH degree and also for doctor in public health. And now he is a professor at Policy and Administration Department. But I would like to say some things about him. In 2004, we have a law enacted. This is a law of SGSN, a law of Social Security. And he has a very significant contribution to the enactments of the law. And also then in 2011, we have PPGS law. Also again, he is have a lot of contribution to that law, so that the GKN concept can be implemented. As you understand, that we have law in 2004, but not until 2014 it was implemented. For 10 years, there is no movement to implement. I guess Professor know that very well to tell us why it happens. And not, of course, a very important note that Dr. Hasbullah now, again, is a professor at FKMUI, but also he is contributing a senior financing specialist at DGSN, at National Social Security Council, who will make advice and provide, what to do to BPJS and also to Ketenaga Kerjaan Security. Well, ladies and gentlemen, I guess that's, I'm sorry, I take a lot of time to introduce the sessions, but we will go for the first session that Dr. Annette will present the presentations entitled that about the implementation of GKN and the family planning under GKN schemes. Dr. Annette, floor and time is yours. Okay, before that I would like to say that the rule of the game of today's session is that we will have our presentations about 20 minutes each, and we have ample time for floor discussion. Thank you.
Is it okay? It's okay. Yeah. Selamat siang. First of all, I'd like to say thank you very much to the organizers for inviting me to be part of this discussion. And I would like to acknowledge Professor Laksono and Professor Siswanto, upon whose work we drew for the analysis of this paper that I'm going to present. And I would like to acknowledge my team who were helping me with the analysis and the presentation. So today my presentation on family planning in the JKN is the family planning and the universal health coverage in Indonesia. And I will be trying to give you a very brief outline of sexual and reproductive health and rights in universal health coverage, and with a background on the evolution of family planning in Indonesia and some background around the family planning status, and then get into the issues around family planning in the JKN. And the central tenet of my discussion is the inequity issue around access and utilization of universal health coverage in Indonesia for family planning. Very briefly, as Professor's already mentioned, universal health coverage was a central issue way back in 1978 and maybe even earlier. But for sexual and reproductive health, we really saw it come to the forefront with the International Conference on Population Development in 1994, and of course with the MDGs, and now with the SDGs, particularly targets 3.7 and 3.8, that really explicitly state access to sexual and reproductive health. And so sexual and reproductive health with contraception is actually something that I really wanted to hone in on in this discussion. And as you all know, universal health coverage really allows us to take the financing arrangements and try and look at how we can reach the goals of effective coverage of sexual and reproductive health service provision, as well as the equitable access to services, and particularly to address the issues around financial risk protection, which is not always well understood when we don't look at the inequity issue in great detail. I'm drawing on a study that was undertaken that compared 6 countries in Asia about sexual and reproductive health service coverage and the financial protection of these countries. And you can see on the x-axis is the financial risk protection index, and on the y-axis is the sexual and reproductive health service coverage index. And somewhere here we can see Indonesia lies. So there are some countries that have better sexual and reproductive health service coverage, and some countries that tend to have better financial risk protection. So we're somewhere in this area. And really this study looked at a broad range, some with some very high levels of sexual reproductive health service coverage and high levels of financial coverage. And the financial risk protection mechanisms took many different forms, including direct public financing of health services, third-party payments for services by a social insurance scheme financed through general tax revenues, as well as insurance premiums, or a variety of them, and pooling arrangements that really related to private health insurance and community mutual funds, as well as cash transfer and voucher schemes. So this really looked at a whole range of financial risk protection schemes. Now, I'm not going to go into all of them. I just wanted to highlight the Indonesia, which initiated the national social security reform in 2004 that Professor alluded to, and also established the insurance schemes for civil servants, as well as social protection for the poor, the Jemkas Mas, and the Jempasal for the maternal and child health. And there's also insurance by the local government, and then of course the JKN, which is the universal health coverage for social insurance. And as you can see, this slide reiterates the medium coverage for Indonesia, and also that all citizens are under one scheme, and that family planning is covered in the national health insurance, and there's medium financial protection. Of course, Thailand has very high coverage, and also has significantly moved along with universal health coverage in a way that will be discussed by others, I'm assuming. Now, I don't want you to go through all of these elements. I just wanted to show you that in Indonesia, family planning, yes, is included in the universal health coverage, but there are many countries in which family planning is not covered in the universal health coverage for various reasons. Some is because they're directly provided by government through the public health system. And in this slide, I wanted to show you, in terms of with Indonesia, that there's about a 66% coverage at the moment, and that the government per person health expenditure is about $38, with about $47 per person for out-of-pocket expenditures. This is, as you see, higher than some countries, but not as high as all of the countries. Okay, so about the evolution of family planning in Indonesia, many of you will already know that family planning as defined as enabling couples and individuals to decide freely and responsibly the number and spacing of their children, and that they have the information and means to do so. Now, this government took that a little bit further in the 2009 and talked about it in accordance with reproductive rights. And that is a welcome from a rights-based approach progress that's seen. And in terms of the family planning program in Indonesia, of course, we all know it's been recognized globally as one of the best in the world. It was a centrally controlled family planning program with extremely strong political support from its initiation in the late 60s. And we saw a dramatic increase in contraceptive prevalence and a decline in the total fertility rate up until about the late 90s. And it's evolved since then with the decentralization and devolution of power and resources, and has taken on a new form with a commitment to universal health coverage by this government. In the 1970s, there was a focus on population control and reaching rural areas. The social norm change that was promoted was really from more children, more welfare to two is enough. And now the thinking is being revised about what should be the slogan, around this, bearing in mind that we've got a demographic transition that's in progress. And then, of course, in the early 90s, the new emphasis was on the involvement of private sector. And then with ICPD, or the International Conference of Population and Development in Cairo in 1994, there was a real paradigm shift in which the rights-based approach was really embraced. And this really shifted to meeting the needs of the individual women and couples, and to the focus on quality of family planning services, which we will talk about in a little while. In Indonesia, 1997 through early 2000, there was significant political reformation and decentralization, as I mentioned, with the economic crisis, as well as change in government, and also the enactment of several rules, regulations around family planning occurred in 2007. But in January 2014, when universal health coverage really came into existence with the JKN era, we've really moved towards talking about the rights-based approach and really trying to look at the 10 elements of rights-based approach. I've put them here, and I'm not really going to talk about them, but they really related to ensuring that the rights of individual women and couples were embraced. Now, this really gives you a bit of a historical slant to the universal health coverage schemes in Indonesia for different populations from 1945 to 2015. And I wanted to show you, of course, on the y-axis is the population, is that over time we have seen the percentage of the population that are not covered by any particular scheme decrease. And we have also seen that there's been a long, significant history of formal sector workers and civil servants being covered by universal health coverage. And also the government has paid attention to the poor, both at the national level and at the rural level, and have ensured that there were schemes in place to cover them. And it's in 2015, right here, that we see that the BPJS has really made its indent in trying to ensure every citizen was covered with universal health coverage. Okay, what of the family planning status? I'm hoping to show you that there has been a plateau in the impact of the family planning program. There's significant disparities both by age and geographic distribution and by economic status. We have a contraceptive method mix that doesn't quite go along with what are the express needs of the population. It's very skewed towards injectables, as in many countries. There are relatively high discontinuation rates in this country, and the supply chain management, commodity security has not quite been met. And so, in addition to the adolescent pregnancies, I want to show that maintaining family planning in the development agenda and also in the health priority is very important for the health and well-being of Indonesians. In this slide, I wanted to show you, this is the contraceptive prevalence rate among married women and the total fertility rate. So you will see the contraceptive prevalence rate on modern method, which is the blue, has increased over time, and then it looks like it's plateaued. It plateaued actually a lot earlier. And the total fertility rate has declined from 5.6, and then after the late 90s has really plateaued to around 2.3, 2.4. And this is a concern because we have reached that level in which it's fairly difficult to go much lower, and also then there's also the issue of replacement level. The unmet need, of course, has, if you will look at the blue, this is the unmet need, and this has remained fairly stable as well. So to really understand the reasons of the stagnation is something that we've been working with the government on, and also trying to look at innovative approaches and actions to be able to address the unmet need, because this is of particular significance, and that's why I'm going to show you the rest of the slides. And this is around the disparity issue. We can see here that We have some provinces with below replacement 1.7 total fertility rates, and others like East Nusantara where the total fertility rate is still very high comparative to the national average of 2.2 or 2.3. And similarly, the CPR shows a similar pattern in which there's significant disparities between provinces, with a CPR of about 70 in Lampang and down to Papua, which is about 23. So you can see that across the countries we have great disparities, and of course a similar pattern with unmet need by provinces that occurs, that sort of maps the impact fairly well. And of course BKKBN has prioritized this difference, and their programming is related to Quadrant that really looks at the low CPR and the high total fertility rates and the focus of their programs. And then of course there's some in which there's some anomalies in which there are high CPR and high TFR, and low CPR and low TFR, which does not quite make sense. And so there's a lot more studying related to that that's ongoing. I wanted to show you that the highest unmet need and the lowest CPR for modern methods. If you look at this, this is the lowest CPR in 1997 in the lowest wealth quintile, and this is the CPR in the 2012 in the lowest wealth quintile, and this is the CPR in 2015 in the PMA 2020 data. And we can see that the lowest CPR and the highest unmet need is actually in the lowest wealth quintile. Now we don't quite see this pattern following through in the 2015 data, because for some reason the lowest CPR is also in the highest wealth quintile, which doesn't quite fit with what we are discussing. But for the most part, the discussion is that, and as an epidemiologist, whether there's significant difference is really related to the confidence intervals, and perhaps I should have put in the confidence intervals, especially with Professor Richard Taylor sitting here looking at this presentation. By the way, Professor Richard Taylor was my external examiner when I was a medical student for my final exam. The highest unmet need for limiting over the years across all wealth quintiles is for limiting. And we see this consistently across the wealth quintiles. And I know I've got limited time, so I'm going to go through this fairly rapidly. The adolescent fertility rates have declined significantly over time, but like the other rates, they've really plateaued since the late 1990s. And reached an unacceptably high rate when you compare it with other countries in the region. This is a similar graph. And when we do further analysis of the adolescent fertility rate, we will find that the proportion of teenagers who have started childbearing is actually higher amongst the urban, and also the less educated, and the teenagers that fall into the lowest wealth quintile. And some of this is thought to be due to the limited access to sexual and reproductive health information and services that are available to them. As health professionals, I know you're very interested in contraceptive method mix, and when I talked about the skewed method mix, you can see that the injectables have increased over time and represent a disproportionate amount of the contraceptive prevalence. The red line really shows the onset of the JKN, and we tried to look at whether there was a difference since JKN started, but we really couldn't given the data that we had. This really relates to the discontinuation rates, and you can see that the discontinuation rates are extremely high, and of course are highest related to condoms and pills. The issues of stockout persist, and even though we say we've got one of the greatest family planning programs in the world, there actually assessments have shown that 27% of SDPs have 5 methods available, but 21% of SDPs also experience stockouts of at least one method, and this has persisted over time and remains an issue of concern. Okay, what about family planning in the JKN? As you all know, the JKN has 3 particular objectives that are already mentioned, and the gross subsidy principle, which is everybody contributes so that everyone can have equal protection. Now, when we examine the essence of that, sometimes we really have to take a step back and think about those that are unable to contribute as much as others. And so this is really an issue that is at the heart of the discussion that I want to have with you today. Family planning has been included in the benefit package since the initiation of BPJS scheme, the JKN, and it covers all types of family planning services, includes counseling, and government covers the needs for all contraceptives. This is in theory, and also the BPJS scheme covers the fee for service either through capitation or reimbursement modalities. In 2014, there's been targets set for the gradual introduction of the JKN, and it is hoped by 2019 that 100% of the population will actually be covered under the JKN. We know that in November 2016, there were 171 million persons registered under the JKN, under BPJS scheme, which is extremely significant when you think about the absolute numbers. It's very high. And so this is an extremely ambitious program that government has committed to implementing over time. There have been many, many laws, I'm not going to go through all of them, that have impacted the introduction of family planning, and many laws about how they need to be, the services need to be delivered at the primary health care facilities and also at the secondary health facilities, and how the payments through capitation, non-capitation, and through the ENA CPG system. So these are the tariffs that are basically in place, and there are 3 premium groups in which the tariffs have been divided, and there's also the PBI, which is those receiving government subsidy, and that's through the JKN. We also can see, this is the graph in terms of the total health facilities that have been covered and the status of where we're at the moment. The target is 22,514. We've got a bit of a way to go. It's increasing, but we've yet to meet the target. The country still maintains 2 registration systems, one for BPJS and one for BKKBN, and so there's a need to consider how that can be better merged. And there's also credentialing of the facilities that occurs with different systems. And unfortunately, only 36% of the midwives are under the BPJS network. I wanted to note this because 60% of family planning users actually go to midwives. And so there's this discrepancy that you will see that relates to this. Of course, and this is the essence of, if there's one slide that I want you to take away, is this one, is that really the JKN has not yet covered family planning for the poor and disadvantaged as it was envisioned. There are about 35 million current users of family planning in this country, and less than 50% of them use the JKN scheme. And the population that's considered poor, as by the definition of BKKBN, is supposed to receive a government subsidy called the PBI or PBI. And not all of those actually receive that. Not all of the poor actually receive this subsidy. Of the 13.5 million low wealth quintile users, the scheme covered less than 60% of them. And you can see that reflected here in this graph, where you can see that the family planning users amongst the poor is quite significantly is quite low. Now, there is an increasing trend of family planning use among the PBE, and the pattern is not that different from the non-PBE. So financing. We have seen that the allocation for the family planning program has increased over the years, but the allocation for contraceptive procurement has disproportionately increased. And this may be something that needs to be further discussed. I'm not going to go through all the slide in the interest of time. Suffice to say that government has allocated significant funding for family planning under the JKNN with BKBN. I did want to spend a little bit of time on the out-of-pocket payments for family planning, because in this we can see that the BPJS members still pay out-of-pocket to receive family planning services. 47% pay of those who access the public health facilities, and 89% of those who access the private facilities in 2015. And a similar trend was noticed in 2016. However, when you compare with the lowest wealth quintiles, we will see that there's much higher, a higher percentage of the lower wealth quintiles than other wealth quintiles that actually pay for out-of-pocket payment for family planning services. And this is shown here with 84% and 90% of the women in the reproductive age group with the lowest quintile paying to access any family planning service at all. Okay, so I know that I'm up against time. I just wanted to summarize very quickly that the challenges that we see in the family planning in the JKN really primarily from UNFPA's perspective, when we think about the Sustainable Development Goals, the equity issue is a very important issue. And the equity issue really shows that the scheme has not yet fully covered the poor, even though there's other schemes available and subsidies available. Those that are disadvantaged still have to pay significant out-of-pocket payments. The services that relate to the facilities in which they have access to are somewhat limited at times. There are many midwives and other private facilities that are not providing family planning services under the scheme. I have to caveat that with the fact that there's tens of thousands of facilities that are providing JKN services, and so this is a significant progress for the country when you think about the absolute numbers. But we still have some issues that we need to resolve around inequities. And the quality of services and competencies of the family planning service providers' variability in terms of the quality assurance system has not been fully established, and the private sector have not yet been fully included and monitored. The big issue, I think, for government planners is really the one around sustainability. How are they going to sustain such an ambitious program with the funding that's available? It's extremely expensive to provide healthcare, as you well know, but the premiums are very low. And so this really relates to how is this going to happen? And is it that mainly the rich are the ones that are having access to JKN and therefore using it, and the poor, who it was who one would like to think it was particularly geared for, are actually not actually receiving the healthcare services. Of course, in terms of administration, there are three different information systems that need to be integrated, and the managers, providers, and community don't all have the same understanding of what's accessible under the universal health coverage with the JKN. So in terms of opportunities, it does provide opportunities for integration of standards and systems and information systems. We have the opportunity to expand with a very strong private sector for increasing coverage. We also have the midwife workforce that could be encouraged to participate, and also the local government fiscal capacity and other innovative schemes to be merged under the JKN for more efficient financing. Finally, we wanted to just make recommendations that really related to the inequity issue around ensuring that the budget for health infrastructure really did cover the least developed areas, and that there was opportunity for review of the premium structure, particularly to close the equity gap, and that there were clear arrangements for outreach, particularly for the Kalchisida, and also attractive incentives for health providers in the most rural areas. And we particularly feel that there's a much greater need to understand what are the drivers of the out-of-pocket or the utilization of family planning, and so much more understanding of the out-of-pocket payment for family planning among the disadvantaged, particularly those that are not using the scheme. And of course, local government to try and use this to make their programs as such much more geared towards them. Issues around improvement of quality and mapping of facilities and protocols, standardization of quality providers, competencies, etc. I mentioned the issues around sustainability, and so a very thorough costing exercise with projections based on the current costs needs to occur, and I'm sure it's probably ongoing, but we had to ensure that this was discussed with different financing modalities merging together. And from a monitoring perspective, really to monitor very closely the financial risk protection that's occurring, particularly for those that are most disparate. I think I don't need to mention anything else because I think I've covered all of it already. And I would like to take this opportunity to say terima kasih. Thank you.
Thank you, Dr. Annette, and ladies and gentlemen, we will continue with the second presentations. Professor Haspola, time is yours.
Thank you, Prof. Hari. Assalamualaikum warahmatullahi wabarakatuh. I would like to start my speech a little bit with the story. The pattern that I use since the beginning to promote the national or JKN. By this time, the story is a little bit less important. The prevalence a little bit smaller, but still happening. The Deborah case, you know, the Deborah. Yes, this story. I took this story from conversation in afterlife. The angel checking the list of the dead people, and the angel asked, "What's your name?" Deborah. And the angels look at the list. "No, you are not in the list. You are not died yet." "Where are you from?" "Indonesia." "Oh, no wonder." Go and take the left, join with the premature dead people for the poor healthcare system. So still happening, but in much less frequency than 10 years ago. Yeah, hopefully this because of the JKN. So if we're talking universal health coverage, we are behind in some other countries. Yeah. Korea, which got independence about 2 days earlier, not about 2 days earlier than Indonesia, already achieved universal coverage in 1989. Malaysia, when was Malaysia got independence? Good. Otherwise, you are in Malaysian. So that's in 1957. So right after independence, Malaysia already achieving universal health coverage because of commitment. In Indonesia, we did that universal health coverage by dividing. This is mostly people don't realize that one. By dividing the role how to achieve universal health coverage, because universal health coverage not only the JKN. Universal health coverage also must cover the health promotion and prevention. If we look at our health law, we divided that for the personal care, or we call it in Indonesia UKP, is managed by BPJS, it is the JKN, but for the health promotion prevention is managed by government, local government and national government. So this is the division of labors. A lot of people criticize JKN as too much curative. Yes, by design it is for the curative, not for the promotive preventive program. The promotion and prevention program is the responsibility of the DINCAS. If you look at the money in 2016, more money went to the government for the, supposed to be for the health promotion and prevention, but in reality, in this area, they also spend for the curative, not primarily on the prevention. So that's our problem. Certainly, some of the health promotion prevention also must be done by, must be covered by the BPJS. This is mostly personal health promotion prevention, like Prolanis, screening, some type of screening to cover. But the major responsibility of BPJS is for the early diagnosis treatment. This is both combination is the 5-level prevention. I think we should use that one. Ahmed already give you some proof in the family planning, but I just want to give you a snapshot of overall utilization. This is just the number. This is coming from the BPJS report. Just the number of visit or utilization. Last year, 121 million visit primary care, 49 million outpatient referral, 7.6 million inpatient care. Half of this year's semester is already achieving this. So it's beneficial. It's benefit for the people. Yeah. But which one who receive the benefit most? Then we should to analyze better. However, a study of SUSENAS, this is National Social Security Survey, found out that about 50% of members did not use for outpatient because of the perceived not good quality, and therefore they have a premature death. Yeah. 20% did not use for the inpatient care. That's from the population-based data. So if you want to evaluate, you have to evaluate not only based on the claim record, but you have to see the population data, because the claim record do not count this out of pocket payment. This is from the IFLS, Indonesian Family Life Survey. We can see the Indonesian Family Life Survey is a survey for the same household every 7 years since 1993. Cover the same household, follow all the behavior of the household. So we can take the effect of the JKN before the JKN and after the JKN. This is the outpatient rate per thousand population. So this is what we measure to be comparative. So you can see increase sharply in the public hospital, but in the private hospital also increase. You can see for non-insured in the private hospital decrease, both decrease. So they will switch the effect. So the effect of JKN with the population-based survey showing improving access. So meaning that we achieve, the trend is to be achieving the target, the goal, but still there are inequities. If we look at the admission rates, also increasing, decreasing in the private sector. In the end, we expect that private hospital also will join the JKN, because at this time, we still cover about 70% of the population, and about 60% of private hospitals are joining JKN, but 40% of private hospitals still not joining JKN. Remember that these rates not only the claim to the BPJS, it's including the one that pay out of the pocket, because we use this the population-based data. So if you compare, this is what we are doing in the DJSN now, comparing between the population-based and the claim-based data to see what the gaps in the access to healthcare. Another study by also one of my students showing the impact of JKN across income quintile. We want to see which group actually receiving benefit. So by looking at the difference of utilization rate before and after across different quintile, we can see which one get higher change. If you look at this data, this is for age above 15 and this above 40s. The difference between the poorer and the richer still there, but the gap is narrower. Yeah, so that means we are moving toward a better equity, but still there are inequity across income group. If we look at the differences across province, then we still have some inequities because of the supply side differences. Yeah. Okay. Yeah, this is another presentation of the equity principle. This for our student in doctoral student. That's good to see this. This is the concentration curve. The concentration curve meaning we will see if there is equity, perfect equity, meaning the line should be across this equity line. This is the poorest to the richest. This is the total number of admission from the poorest to the richest. In theory, when it is very equitable, 20% of the poorest people will consume 20% of the total admission. 40% of the poorest people will consume 40% of total admission. So whatever there is equity in the equity line, that's meaning that's equitable. So in this case, we can see this is before the JKN 2007, and this is after the JKN, the blue one, 2014. We can see both for age group shifting from inequitable, so the farther the line from the equity line, the more inequitable. So we can see the impact of JKN is increasing. The same results are provided by evaluation by TNP 2K on the Susunas data 2011-2016. So it's consistent, meaning that the JKN already reaching a good trend to achieve access for everyone. However, a lot of people complaining. If you check in the internet, in the seminar, a lot of complainings. Yeah, because the BPJS deficit, amburadul means hazard, hectic. There's no English word. Going bankrupt, yeah, and so on. So that's kind of belief. Most public health people say, if we continue providing curative care, the country will go bankrupt. Often the government always say that. I said, where did the theory come from? Where is the evidence? So I would like to show you that one. Why? Because the surface is not good and queue very hard, very long. People complain, and also, as Annette mentioning, the fund very, very small. Objectively, we can measure how good is DJKN by using this cube. The WHO provided a concept of this cubic. So this cube is population covered, currently 182 million according to the BPJS data. So meaning that 70% of the population covered. This vertical is the depth, meaning how many percent of the total health expenditure covered by the JKN. And we found that from 2014 and 2016, only 15 to 18% of the total expenditure actually contributed by the JKN. That's mean it's imbalance proportion, not the proportionally sharing of the population and health expenditure. And therefore, the out-of-pocket still high, as shown for the family planning. Not only for the family planning, for other outpatient, inpatient care also, they're still high. So we are going to fix that one in the next couple of years. And the service is comprehensive. Comprehensive meaning from promotion to palliative care. This is being questioned by people. If we have a small amount of money, why we have to cover comprehensive care? Why not prioritizing some most important? But it is not easy politically. Technically maybe easy, but when you go to the Congress, the Parliament, they said no, we want to cover comprehensive care. Yeah, so we have to still fight up. Okay, and another way of looking is to see how much money we spend. So this is my only area of knowledge. Since 20 years ago, I just looking money, but I don't have money. Just today, so if you look at the Indonesian, this is the Indonesian trend in the health expenditure as percent of GDP. You can see this is Thailand. Thailand's going very high. Good commitment by the government and the people. Indonesia, well, Indonesia, since we have a culture of ngerumpi, talk more. Then we can see this has been kind of plateau, like the family planning. So, I hope no one from Ministry of Health from here or BPJS. Then they will complain my criticism. Yeah, but this is academic, so we have to evaluate to see where should we go. Because the main problem is the government's not consistent. Politically, the government say, and also the parliament member, the politicians say, we will prioritize health. Health is priority. That's important. Many of the politicians always promising when they go for the election, we provide free health care. Yes, free for the paracetamol only. That like puskesmas, you know puskesmas stand for pusing-pusing, keseliu, masuk angin. That simple disease. Yeah, for the same simple disease, the drug is the same, paracetamol only. So that's considered priority. That's a problem. So I think we have to fight more on this. That's our homework for the future. Yeah. This is maybe a better look at the trend in Indonesia. Yeah, this is from National Account. The work of Mardiati, Bu Beki is working on this one. You can see in terms of GDP, we still have a stagnant. If we are improving, then we should spend more, because on average, many developed middle-income countries spend already 5% of GDP. So we've been spending only 3%. If you consider the JKN contribution only 18%, meaning that the JKN contributes only 0.60% of GDP, very low. With this investment, how can you reach good quality of people? How can you extend life? So therefore, still a lot of premature deaths. Yeah. If you want to check our quality of life, very easy. Check our medals in our previous SEA Games in Kuala Lumpur. Yeah, we are ranked. We were in the 5th rank, right, in the ASEAN. Our population in the 1st rank. Very high discrepancy. When I check in the ASEAN Games in Seoul 2015, our rank was 17 in Asia. The population size, we are the 3rd. When I corrected, this is the problem with the medal in the parliament. Yeah, when we corrected with the population base, our rank was the 40th. Too bad. Yeah. So I run out of time. Another comparison, just you look at this. You want to do more, then you can attend my class or you read my book. Yeah. Okay. So this is another way of benchmarking JKN. See, out of pocket is important measure. We are still far behind. Yeah. Up. Yeah. So million of people get benefit and so on. You can read this. The main point of this, we are still having big problem with our JKN. A lot of thinking that we are not able to do it because of our fiscal capacity. And a lot of people saying we cannot afford. I think we can, not I think. The fact is we have fiscal capacity. This is the evidence that I gather to prove that don't worry with universal health coverage, because no evidence that after universal health coverage a country going bankrupt. So this is the dot is the year they achieve universal health coverage. All other economies increasing. So we don't have to worry about that, but we have to convince politicians and so on. What about public health? Again, there's a lot of money not doing well by the government. You can see this, one more minute, yeah? You can see this trend of the budget. The health budget are the lowest. Education is okay, good one. This is the main problem, oil subsidies, energy subsidy. We spend too much for oil subsidies, yeah? It's good in the Jokowi, they already decreasing subsidy, but still the health not doing it. So this switch to infrastructure, health is not yet being paid. This is another way of looking how big the government commitment to spend for healthcare. Money is not the only factor, but money is the main factor to ensure equity. Yeah. You can see this is also spending of the Ministry of Health budget. You can see even Ministry of Health budget, they're supposed to focus on prevention and prevention. They still have a lot of money going to a hospital. This includes the JKN. You can see they're spending not for the public health also, although the main thrust is public health. So those of you who are coming from Ministry of Health, please reform your program in the future. Yeah. Otherwise, we will have a big problem. Oh, so this is another way of doing that. You can read. I think many of you are graduate students. Yeah, you can read this graph, right? Key takeaway: we have a lot of mistake in the understanding and making the JKN sustainable. I think the main problem for us is the mindset. The mindset of this one, and therefore we have to treat completely. Maybe we need radical surgery for the JKN to make sure the JKN will continue to grow. Thank you very much.
Thank you, Prof. Hasbullah, for your blessing. Yeah. Okay, dear colleagues, we still have about 15 minutes for discussions, and I will invite you who want to say some things or make comments or enrich the informations. Please tell your name, your institutions, and to whom your question is directed. We would like to, please. Yeah, okay. Please start with the first question, second, and third. Suggest that we still can entertain it. No questions? Okay. There's one over there.
If you have no question, you can argue with, you can
and then Prof. Hadi here, and then the third here. Okay, like I said, stop right there. Please tell your names, your institutions, and to whom your question is directed, and then Prof. Hadi, and then in the middle.
Okay, hello everyone. Let me introduce myself first. My name is Tifal Sabina. You can call me Tifal, and I'm from Faculty of Public Health, University of Indonesia. And I would like to ask some question for Prof. Hasbulo. You said that the last presentation that you showed that we have to strain the mucus itself. So, what kind of the best effort for me as an undergraduate student to help strain the mucus itself? It was to educate or something. So would you mind to give us or recommend what kind of the best effort for straining the mucus itself? Thank you, and thank you for this chance.
Prof. Hadi, please.
My name is Adi from the Faculty of Public Health. I would like to have the reaction from the two speakers. Dr. Anet, you mentioned in your presentation that one of the issues is the financial sustainability. And Prof. Hasbulo also mentioned that health is not priority in our country, even though it's spoken, it's yes. So I just would like if both of you could brainstorm us, what is the breakthrough recommendation to make sustainable financially? Thank you.
Thank you, Prof. Hadi. Please.
My name is Nani from Faculty of Public Health, University of Indonesia. I want to ask a question from Mr. Hasbulo. What should we answer the issue of the BPJS is bankrupt? Yes. So many issues of that the BPJS is bankrupt. So how can we answer that issue? Thank you.
Okay. Dr. Anet or Dr. Hasbulo, you want to?
Sure. To start the discussion around the issue of sustainability, I think Professor Hasbulo showed us the relatively low percentage of the budget that's allocated to health, and that's a particularly important issue that needs to be thought about, and that would give a higher percentage of the government dollars towards the JKN scheme. But I would like to also go further and talk about the need for public-private partnerships. And I think this is very important because you've got a very active private sector and you've got some extremely wealthy people in this country. And so encouraging health benefactors to also provide contribution to the JKN for the sake of everyone or for particularly the poor, maybe something that needs to be looked into in more depth. I think, of course, as I mentioned, there's a real need to do some actual costing, and I know that this is probably going on, so I shouldn't say need, but the costing issue based on the population projections with real actual costs at the subnational level. And the reason I say this is that we know that there's a devolution of power and resources to the decentralized subnational government. So involving the subnational governments in the allocation of funds for JKN to reach groups is also another area. But I think I will hand over because really the expert is sitting to my left.
Thank you, Annette. Yeah, I think the three questions are interrelated, mostly also relate with the funding, with financing. All of those problems, as I said before, are related with the mindset, behavior of our official. So if you were asking me about how to strengthen the DINCAS, first make sure that if you are in the DINCAS, throw away all selfishness of your work. I observe a lot of selfish DINCAS because some of the people said, if I do have promotion prevention, I can reduce the incidence of disease. The BPJS will benefit from me. So not ours, not DINCAS. Don't look at your role, but look at the people role. When you do strengthening public health program, it is the people that you serve. It is the people money that you use. Similarly, in the BPJS, they use people money, not their own money. So they be wise in spending people money for the people, not for us. Yeah. For example, for the DINCAS, for the health promotion, at the same time we started with the JKN 2014, we also started to charge 10% cigarette tax for the local government. That's 10% of cigarette tax. This year is amount about 15 trillion rupiah. And at least 50%, that's the law said, 50% of those money should be used for health, especially for the fighting tobacco control, law enforcement, fighting public health. But if I look at the evaluation of the money used for this body, it's not absorbed. Why? Because the DINCAS didn't have ideas. This is different from normally APBD, when the DINCAS traditionally programmed the program and taking 10% increase from previous years for the same program. This money require innovation by the local government. What is program that you want to do it, you propose, and the money is there budget. But the money is not absorbed. So that's it's simple. Maybe when you are here in the school, learn how to propose good program for the public health prevention and promotion. Don't worry that in the end the BPJS claim will goes down, but will not be goes down. Yeah, it will increase a little bit. So that one. So the breakthrough of funding, as Annette mentioning, there are a lot of people who have ability to and willing to pay more, but the regulation set the contribution with the ceiling 8 million, meaning the higher income with 8 million rupiah is only 800 Australian dollars. So all to have a high income, $2,000, $3,000 only pay 5% of 800. So there is no cross subsidy between the highs and lows. But this is again the mindset of the government and the Congress, the parliament member. A lot of this is no one. BPJS bankrupt? No, BPJS will not go bankrupt. Deficit in BPJS is common. If you look at the deficit of our APBN, our national budget, it's been more than 20 years always deficit. Check. Yeah, the deficit is even set limit 3% of GDP. This year the deficit is 300 trillion. Lots of money. And the law says if the deficit shortage of money, the government should finance. So it never happened, BPJS go bankrupt. Don't worry about that. Thank you.
Okay, my dear colleagues, it's not that we have, we run out of time, and I guess it is time to complete these sessions, but allow me to just say some things. It's very difficult actually to make conclusions. But first of all is that we need to, if we are discussing the universal health coverage from the, the government or country point of view, we need to talk about the populations. How much percentage of the populations is actually, is protected, one, and or have insurance actually. And the second is financial risk. Actually, how much, if in reality we are talking about how much out of pocket is actually still done by the peoples. And the third is actually talking about benefit coverage, whether it is comprehensive or it is limited. And on the family planning, one thing that is very important to know, that family planning is now actually implemented rights-based family planning program, and the impacts of the family planning program state plateau. The TFR is still very high. Well, I can say it's still high because 2.28, and varies among provinces. Again, the lowest one is Yogyakarta, and the highest is NTT. And current prevalence rates, current users, it also varies from province to province. But very important notions made by Dr. Annette is that JKN has not yet covered family planning for the poor and for disadvantaged. You know, there are still a lot of things, there are still a lot of unmet need, as Dr. Annette put in the presentation. And I guess that Dr. Hasbullah presentations just one say that it's very important. Don't worry that BPJS will be bankrupt. No, that one. And the second, for you who are working with DINCAS, the district health office, provincial health office, which actually you have a mandate to make public health actions or public health programs. Don't be selfish. That's what Asmullah said. Don't be selfish. Do it, rightly, and also best. It doesn't, well, it will that actually the cumulative, people will go down, the number of people will go down for cumulative demand, but it is okay. It doesn't mean that you make BPJS people richer. That's what you're saying. So again, I guess that one thing that we are actually, Indonesia, our country, is in the progress of, achieving universal health coverage, but maybe still far away. But also the time that we should look at is still, we still discuss this kind of matter in 2020, because 2019 is actually, it is mandated that everybody should be registered with BPJS. I guess that's my very short, understandings of your presentations. Let's show our appreciation to the speakers by giving them. Thank you very much, and also appreciation to you all that you are still here with a very abundant energy.
Thank you very much, Prof. Anhari. I'm inviting Prof. Anhari and all speakers to the stage for a handing of token of appreciation as well as a group conversation. And the token of appreciation will be given by the Dean of Faculty of Public Health, Universitas Indonesia, and after the chair of the conference. Thank you. To all participants, please do not go out from this room, because after this we will directly have our closing ceremony. Once again, thank you very much for the moderator speakers. Our last plenary, a very fruitful, valuable presentation today. Again, please do not leave this auditorium yet, because after this we will have directly our closing ceremony. Graphication. Thank you very much. Thank you.
We'll arrange our discussion.
Thank you very much. So again, to participants, we still have one last agenda, the closing ceremony of the Faculty of Public Health Universitas Indonesia Science Festival 2017. So please don't leave this room. The certificate can be taken after the closing ceremony. All the organizing committee are actually now here in this room, so you cannot take your certificate now, but after this. So please. For a while we will start our closing ceremony. Fruitful 3 days of event. I actually have a lot of questions to the speakers. However, because I have the master of ceremony, I don't have the opportunity, but maybe later. Next year, I'll be the participant, because very good presentations for all the speakers. Again, to the participant, please do not leave this room. We still have one last agenda before we can take your certificate. Assalamualaikum warahmatullahi wabarakatuh. Again, good afternoon. Welcome for the participants who just arrived. Welcome to this room. Excellency, the Dean of Faculty of Public Health Universitas Indonesia, and also the Chair of the conference, Dr. Agustin Kusumayati, Vice Dean, Dr. Sabarina Prastio, our honorable scientific committee members, also of course the honorable invited speakers, our resource persons from all of the universities, institutions in the region. And last, of course, to the distinguished guests, the valuable participants, ladies and gentlemen. Thank you very much to attend our last agenda in this Faculty of Public Health Universitas Indonesia Festival 2017. closing ceremony, I would like to invite the coordinator of international meeting on public health, Faculty of Public Health Universitas Indonesia, to give the report of the meeting. To Mr. Supriyanasi, I'm inviting you to give the report. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. Good day, ladies and gentlemen. First of all, on behalf of the conference organizers, I would like to express my gratitude to all of you who have come together here from various places and countries. Thank you for your cooperation, which has enabled us to conduct a highly fruitful conference. Faculty of Public Health, Universitas Indonesia Science Festival 2017 comprises two international conferences: the third international meeting of public health for postgraduate students and the first Young Scholar Symposium on public health for undergraduate students. The conferences are designed to encourage students of all degrees to participate and contribute their ideas concerning SDGs. In this morning, I would like to present the conference report as follows. We have conducted pre-conference followed by 32 participants with two pre-conference workshop topics. The topics of workshop was writing article for international publications and geographic information system, real-time monitoring for public health. And then for the conference, a total of 2,002 participants joined with this conference from 2 countries and 1,200 sit-in participants. A total of 34 speakers attended from 12 countries. 3 plenaries and 12 symposiums have conducted. 113 oral presented from 174 abstract accepted with 30 of topics. And a total 65 scientific posters presented from 139 abstracts submitted. Not only offered wide range topic of paper, there was a performance competitions in addition to this event, and we have received 10 short movies, 76 photos and 60 health promotion posters, which that the winners of art performance competitions will be announced soon. After the conference, we will be continue the relationships established through this conference. So in the future, we will be able to respond together to issues that we have in this conference and achieve our common objective related to our students' competencies. I would like to especially express my appreciation to the President of Universitas Indonesia, the deanships, all of speakers, lecturers, students, and members of International Advisory Board, steering, scientific, and organizing committee, and of course, for our sponsors. And thank you once again to those, the ladies and gentlemen, who had worked behind the screen. There is a nice team behind that makes up the whole organizing support staff. These folk work tirelessly and still smiles on their face. They deserve another round of applause and appreciation. Ladies and gentlemen, please big applause for them. And for everyone with the purple uniform, stand up please. Okay, thank you very much. Finally, to you all, thank you very much for coming and joining with us today. We look forward to your participation in future events. See you again and have a safe journey. Thank you very much.
Thank you very much, Mr. Ketua. And ladies and gentlemen, recently, as part of this festival, Faculty of Public Health Universitas Indonesia also opened a creative competition about public health in 4 categories: photograph category, poster, short movie, and a scientific poster competition. And now, there will be the announcement of the winner of all categories competition. And for that, I'm inviting Ms. Kartika Anggun, Dinar Setio MKM, as the coordinator of the Young Scholar Symposium on Public Health, to announce the winner. Floor is yours.
Good afternoon, everyone. This year, the first YSOP had successfully conducted 3 competitions. This competition were held from 14 August until 7 of September. I would like to say thank you for all the participants, our professional judges, and everyone who gave their vote for favorite category. Our participants come from various provinces in Indonesia. Please cheers up for them. And now, the name of the winners are already on my hands. I'm so excited to announce right now. I'm so excited. The first category is for photography competition. The most favorite photo who earns 294 likes on Instagram is from Poltekkes Kemenkes Makassar by Rudianto. And the third winner of photo competition from Institut Seni Indonesia Surakarta by Muhammad Nur Hamza SA. And the second winner of photo competition from Universitas Sumatera Utara by Edi Satria Hartono. And the first winner of photo competition from Universitas Muhammadiyah Yogyakarta by Arif Rahman Hakim. Okay, I will move forward to poster competition. The most favorite poster who earns 322 likes from Poltekkes Kemenkes Makassar by Justin Pakan. The third winner of poster competition from Banjarmasin by Adi Nugroho. And the second winner of poster competition from Universitas Indonesia by Dia Alamanda. And the first winner of poster competition from Universitas Erlangga by Kirana Dwiyanti Prasetyo.
Thank you very much. We invite all of the winners for these 2 categories to kindly come to the stage. Yes, to the stage, where we will be handing off the prize. All of the winners for 2 categories. This one is for poster category and for the photo category. Yes, only 4. This is poster for photo category. Okay, for this one, the poster category, the prize will be given by the Dean of Faculty of Public Health, Universitas Indonesia. Okay, the photo winner. Okay, you can come to the stage. Yes. Okay. Congratulations to the winners. Okay. Thank you. And the last one. The last one for the poster category. Once more. Okay, last one. last one, we invite Dr. Agustin to have photo session. Okay. Once again, congratulations for this young generation who are very literate about public health. Thank you very much. You may go back to your seat. Thank you very much. Congratulations once again.
Congrats to the winners. I will move forward to the short movie competition. The most favorite short movie who earns 166 likes from Institut Teknologi Bandung by Eldora Usuli, and the third winner of short movie competition from Universitas Sriwijaya by Putri Rizky, and the second winner of short movie competition from Universitas Indonesia by Afra Inayah Yani Putri, and the first winner of short movie competition from Universitas Lambung Mangkurat Lampung by Muhammad Ihsan Al-Farisi. And I have another one competition. This is for the most favorite scientific posters. This is voted by all of you guys who put the stickers on your favorite posters. So I will announce the most favorite scientific posters are Tiara Mairani, Universitas Indonesia, Amalia Indah PS, Universitas Indonesia, and Sigi Wibowo from Universitas Indonesia.
Congratulations once again to all the winners whose name are mentioned. Please. So this is all from Universitas Indonesia. Congratulations. Please come forward to the stage. There will be a handing of the prize. If you're not coming, I will take the prize. Okay. Congratulations. Again, we invite Dean of Faculty of Public Health Universitas Indonesia to hand the prize. And after this will be continued by a group photo session of these winners. Photograph? Okay. 1, 2, 3. Congratulations once again to all the winners. Yes, you may go back to your seat.
Congrats to all the winners, and see you again on the next year competition. Be prepared for yourselves.
Thank you very much, Ms. Tika. And distinguished guests, I would like to invite you to watch together the touching moments of the result of our last 3 days activities here in Faculty of Public Health Universitas Indonesia Science Festival 2017. Without waiting any longer, enjoy the clip. strong as I, true as it can be. And even fast than somebody else unexpectedly. Just a little change, small to say the least, but the least can neither one prevent beauty and the beast. Ever just the same, ever a surprise, ever as before, ever just that sure as the sun will rise. Ever just the surprise, ever as before, ever just as sure as the sun will rise. Till as long as tune us on the song, be the sweetest strange, finding you can change, learning through a wrong. Certain as the sun, rising in the sunless all that's light, strong as all that's light, Good afternoon, everyone.
Good afternoon.
Okay, maybe before we go to the next song, we would like to introduce ourselves first. Maybe you first.
Okay, my name is Tita. I'm one of the alumni from Faculty of Public Health. I'm here with Kak.
Okay, hello everyone. My name is Zaki Tifano. I am alumni of Faculty of Public Health, batch 2010, so long ago. Okay, from majoring in occupational health and safety. K3, mana K3? Anak K3 ada suaranya? Okay. Okay. So we both alumni. Katita is batch 2012, right?
Yes, and right now, currently, I'm one of the staff at Department of Nutrition Study at Faculty of Public Health.
Okay, so when the committee asked us to perform in the closing ceremony of IMOP, we would like to present you two songs. The first song is Beauty and the Beast from Celine Dion and Peter Bryson.
From Disney.
Okay. And then the next song, maybe this is an Indonesian song, can relate to most of the participants here, from Glenn Fredly and Yura Yunita, Cinta dan Rahasia.
Please enjoy. tak bisa kau salahkan.
Ku cinta padamu, namun kau milik sahabatku. Dilema hatiku, andai ku bisa berkata sejujurnya. Kau pilih dia, pilihlah aku yang mampu mencintau lebih dari dia. Bukan ku ingin merebutmu dari sahabatku, namun kau tahu cinta tak bisa kau salahkan. Lebih dari dia. Bukan ku ingin merebutmu dari sahabatku, namun kau tahu cinta tak bisa kau salahkan. Tak bisa kau salahkan. Tak bisa kau salahkan.
Zaki and Tita, alumni of Faculty of Public Health Universitas Indonesia. Thank you very much. Thank you for the beautiful voices. Thank you. And so, ladies and gentlemen, I would like to officially announce that today's agenda is all done. And for that, I would like to invite the Dean of Faculty of Public Health Universitas Indonesia, who is also the chair of the conference, to give the closing remarks.
Bismillahirrahmanirrahim. Ladies and gentlemen, unfortunately the last song is in Indonesian. Otherwise our international guests will also like us. We call it, our feeling is just go together with the song. The song is telling about someone who falling in love to someone that actually the fiancé of his or her good friend. So the song said, please don't choose him or choose her, but please choose me. That's the song. So it's really expressing the feeling of most of the students, yeah? Okay, Bismillahirrahmanirrahim. Honorable speakers and resource persons from various universities and institutions, my dear colleagues, professors, lecturers from the Faculty of Public Health of various universities in Indonesia, distinguished participants of the conference, ladies and gentlemen, very good afternoon. Assalamualaikum warahmatullahi wabarakatuh. I'm so grateful to have you all in this very last session of this science festival. Let's thank our God Almighty, Allah Subhanahu wa Ta'ala, for His blessings and the good health that He grants us during this 3-day conference. A proverb says that in every meeting, when we say hello, there always be a time when we have to say goodbye. So, here we are now. It's a time for us to return back to our home. It can be our home country, our hometown, as well as our home institution where we work and study. I really hope that during these 3 days we have shared and learned something. At least we have met friends and new friends. And I hope that all of you have good time with these great friends. Friends are actually the most valuable things in our life. Together with our good friends, we will be able to create unlimited good things. So, we have good friends here. Please keep in touch and let's make better future of our one world. A world with a peaceful, healthy, and prosperous life for all people of all nations. At the time when we have to part, let me convey our true feeling to all of you. First, thank you. I thank you for your presence, your contributions to make the Science Festival really something to be remembered for us. I also thank all the committees, the scientific committee and the organizing committee for the hard work so that this conference can go very smoothly during these 3 days. Second, please apologize us for every single thing that has made you upset and unhappy. Please accept our apology. And third, see you again. I believe that our bye today will be a good bye, and we will meet again someday, somewhere, for something which is much more significant and meaningful. By saying thanks to God Almighty, Alhamdulillah Rabbil Alamin, I declare that this 2017 Faculty of Public Health Universitas Indonesia Science Festival is officially closed. We wish you a safe and pleasant trip back. We wish you all a safe and pleasant trip back to your home country and home city. May God bless you always and see you again. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for participants. We would like to